Today, we're diving into a really fascinating genetic mystery, iAMP21. It's a high-stakes subtype of pediatric leukemia that literally demands some absolute meticulous clinical detective work. So whether you're gearing up for your boards or you're just a fellow genetics and oncology nerd, you are absolutely in the right place. We're going to break down the clues, spot the red herrings, and ultimately reach the diagnostic verdicts that actually save lives. Let's get right into it. So here's how we're going to map out our investigation today. First, we'll cover the basics of iAMP21, then look at initial tests and some sneaky red herrings. After that, we're tackling the FISH diagnostic trap, moving into advanced genomic testing, and wrapping up with treatment and MRD tracking.
All right, part 1, the basics of iAMP21 and understanding our suspect.
The most crucial thing to grasp right off the bat is that iAMP21 isn't simply an extra chromosome. That's a super common misconception. It actually stands for Intrachromosomal amplification of chromosome 21. So what we're really looking at is a single structurally abnormal chromosome 21 that's become highly, highly unstable. Through some insanely complex biology, it has duplicated, amplified, inverted, and even deleted its own internal segments. And a key region that gets amplified in all this chaos includes the RUNX1 gene. That's a vital gene for normal blood cell development, and it's the very marker we use for diagnosis. Think of it like a book. It's not just having a duplicate copy of the whole book. It's like someone took one specific chapter, copied it over and over again, and just shoved it all back into a monstrously thick, unreadable spine. So who actually gets this? Well, your classic exam vignette is going to be a child right around 9 years old. And as you probably know, that's slightly older than your typical childhood acute lymphoblastic leukemia demographic. They make up roughly 2% of childhood BCPLL cases. Clinically, they present with standard acute leukemia symptoms, pallor, fatigue, bruising, and often a relatively low white blood cell count. But here's the kicker. There is absolutely no outward physical sign or unique clinical syndrome that points to this specific anomaly. You can't just look at the patient and guess iAMP21. You literally have to hunt for it. Moving to Section 2, Initial Tests and Red Herrings. Let's look at the initial workup. When a kid comes in with these symptoms, obviously your first steps are blood smears, bone marrow aspirates, and flow cytometry. And under the microscope, the blasts just look like standard B lymphoblastic leukemia. Flow cytometry is going to confirm the B lineage, showing you the usual markers CD19, CD22, TDD. But honestly, do not get fooled here. There is no specific blast morphology or pathognomonic flow profile for iAMP21. The marrow and the flow are absolutely essential to prove it's BAL, for sure, but only the genetics can definitively unmask the iAMP21 culprit. Which brings us to Section 3, the FISH diagnostic trap, or what I like to call the golden rule decoy. Historically, diagnosing iAMP21 relied heavily on one specific number, 5. During routine FISH screening, where pathologists literally use glowing fluorescent probes to light up specific genes in the cell, they noticed cases with multiple extra RUNX1 signals clustered together. So the classic cytogenetic rule of thumb became this. You need to find at least 5 RUNX1 signals per cell, with at least 3 of those extra copies clustered on a single abnormal chromosome 21. But here is the absolute biggest exam trap you're going to face, and frankly, a massive pitfall in real-world diagnostics. If a pathology report hands you 5 or even 6 RUNX1 signals, does that automatically guarantee we're dealing with iAMP21? Well, the answer is a resounding no. This perfectly illustrates the decoy. Let's compare high hyperdiploid ALL, where a patient has an abnormally high number of overall intact chromosomes, with iAMP21 ALL. Both of them are going to show multiple RUNX1 signals, but the why is entirely different. High hyperdiploidy gives you multiple signals because the patient literally has extra, whole, intact copies of chromosome 21 just floating around. They're completely separate chromosomes. iAMP21, on the other hand, features multiple signals clustered inside one single, highly mutated chromosome. So if a test just spits out 5 RUNX1 signals without telling you the localization, you do not actually have a definitive diagnosis yet. Let's hit Section 4, Advanced Genomic Testing. It's time to escalate our tools. What's truly fascinating is this massive 2022 study by the Mayo Clinic and the Children's Oncology Group. They looked closely at over 200 cases and revealed that roughly 9% of confirmed iAMP21 cases completely missed the classic RUNX1 FISH criteria. 9%. Some had fewer than 5 signals, some had signals scattered weirdly. Basically, almost 1 in 10 times, this leukemia entirely outsmarted the standard diagnostic rulebook. So to catch that sneaky 9%, we really have to escalate our techniques. Tests like chromosomal microarray, or CMA, and metaphase FISH are absolutely crucial here. Metaphase FISH is super powerful because instead of just counting glowing dots in a nucleus, it shows us exactly where those signals physically sit on the chromosomal architecture. CMA goes even further. It reveals the characteristic, complex landscape of amplifications and deletions. It's almost like scanning a corrupted barcode across the entire chromosome. If that initial pattern looks even slightly suspicious, you absolutely must escalate to these tools. Finally, Section 5, Treatment and MRD Tracking, where we make those critical clinical decisions. Why does distinguishing iAMP21 from hyperdiploidy matter so much in the real world? Because missing this diagnosis is incredibly dangerous. Historically, when these patients were given standard risk therapy, they had unacceptably high relapse rates. They were quite literally being undertreated. Today, we know for a fact that identifying iAMP21 mandates appropriate, intensified, risk-adapted chemotherapy. It's an adverse risk subtype if you undertreat it, but when you hit it with the right intensified protocols, their outcomes improve considerably. It's a real game changer. Once treatment kicks off, we run into one final potential trap. After induction therapy, just looking at a morphologically clean bone marrow smear, meaning less than 5% blasts under a microscope, is simply not enough. A patient can be in morphologic remission, but still harbor incredibly dangerous leukemic cells. You have to rely on advanced multi-parameter flow cytometry or molecular approaches to track minimal residual disease, or MRD. You got to ensure absolutely zero aberrant cells are hiding out, because MRD status is one of the absolute strongest predictors of long-term success. Okay, let's tie this whole thing together into a master workflow. If you follow this exact step-by-step diagnostic process, you're pretty much guaranteed not to miss this. Step 1, suspect BAL from the CBC and marrow. Step 2, confirm that B lineage with flow cytometry. Step 3, screen the genetics with a standard panel. Step 4, and this is the make or break step, clarify those RUNX1 copies. Are they extra whole chromosomes, or are they clustered on one? Use metaphase FISH or CMA to find out. And finally, step 5, definitively diagnose iAMP21, establish that MRD baseline, and get them started on intensified therapy. If you're ever put on the spot during clinical rounds or on your boards to summarize this entire explainer, this perfectly crafted statement is the exact answer you want to give. It nails the mechanism, intrachromosomal amplification. It names the primary pitfall, high hyperdiploid BALL. And most importantly, it states exactly why it matters for the patient sitting right in front of you, because appropriate intensified therapy substantially improves the outcome. It hits the nail on the head. Cracking the case of iAMP21 is without a doubt a triumph of modern genomic medicine. But it leaves us with a really fascinating thought. If just one chaotic, highly unstable chromosome in just 2% of patients can completely upend our entire clinical strategy, turning a standard risk into an intensified risk, what other genetic masterminds are currently waiting to be discovered in the remaining 98% of pediatric leukemias? The genetics of cancer are vast. It's like a giant puzzle, and the investigation is always ongoing.